So next up, we'll have a little more on hematologic malignancies. Dr. Bhagirathbhai Dholaria, he also overlapped at University of Arkansas. I don't know if at the same time, if y'all were both there, for his residency, and then went to Mayo Clinic for his oncology training. And he's over at Vandy now. He does a lot with CAR T cells. And so today we're going to be talking about all the same difficult decisions for changes in how we manage our patients with diffuse large B-cell lymphoma. And now there's so many drugs that have gotten approved over the last few years, upfront, relapsed. And so I look forward to hearing what we have to say.
Hello, everyone. Thank you for joining us today in this wonderful meeting and inviting me for this conference. Coming to Memphis always bring back good old memories during the residency days when we used to drive after 24-hour call in ICU, get barbecue at Rendezvous, play some pool on Beale Street, and go back to Arkansas to start another 24 hours. So, but these are the good times. So I'm Bhagirathbhai Dholaria. I'm assistant professor at Vanderbilt University in Nashville. And I'm a transplanter by trade, though all of us are now evolving into cellular therapists. And my talk today will cover different aspects of management of relapsed or refractory high-grade B-cell lymphoma or diffuse large B-cell lymphoma. In next 20 minutes, I will go over the landscape of relapsed refractory DLBCL, how it has changed in last 4 to 5 years with advent of CD19 CAR T-cell therapy, as well as other non-CAR T agents, which has been FDA approved, and many more currently in the pipeline. These are my disclosures. I'll be discussing some non-FDA approved indications for some of the drugs. We'll start with the historical background of how the traditional outcome of relapsed refractory DLBCL is. What is the standard of care has been over the last couple of decades now. How the CAR T therapy has changed all of this in last 2.5 years. And we're gonna go over quickly some of the new recently presented results of the phase 3 studies and phase 2 studies looking at the role of CAR T therapies in a second line and even first line for high-grade B-cell lymphoma. And in the end, I will summarize everything and try to synthesize the data for you where you can analyze and also implement these results for the next high-grade lymphoma patient you see in your clinic next week. So pre-CAR era, for the last almost 25 years since the publication of PARMA trial in 1995, the high-grade B-cell lymphoma, once they fail R-CHOP or CHOP, the treatment pretty much is platinum-based salvage therapy. If they respond, take them to high-dose therapy, followed by autologous stem cell transplant. You cure roughly half of these patients. If the patients do not respond to salvage therapy, or if they are not eligible for high-grade therapy and autologous transplant, then options are extremely limited. Most of these patients will succumb to their disease and will die within less than a year. Very few patients will go to allograft. Allograft still has a role, but that in a very limited setting. So this is the outcome, more recent cohort of autologous transplant in high-grade B-cell lymphoma, and you can see here roughly 50% long-term progression-free survival. So these are the patients, of course, who are fit enough to receive the salvage therapy, and they responded to salvage therapy and went to the transplant centers, and then half of them lived long-term. This is a recent CIB-MTR updated summary statistic showing the outcome of allograft in a relapsed DLBCL or high-grade B-cell lymphoma. And again, roughly half of the patients are cured. But as with all transplant studies, there is a selection bias here. These are the healthiest of the healthy patients who had chemosensitive disease and went to the transplant. In the reality, this is what we see. This is a ScholarOne data, large retrospective analysis from academic centers looking specifically at the highest of the highest risk DLBCL patients. These are the patients who are primary anthracycline refractory, patients who had relapsed within a year of transplant, or patients who failed to respond to salvage therapy. And these are the patients who never see a transplant doctor. And this is what community doctors deal with every day in and out. And you can see here the response to the next line of therapy in these patients are only 26%, and the 2-year overall survival is merely 20%, okay? And there is an urgent need for novel therapies for these high-risk patients, and that's where it changed when the first CAR T therapy was approved. So I'll walk you guys through currently FDA-approved CD19 CAR T therapies. We have total 3 drugs approved right now for FDA for these indications for beyond second line. So this patient has to have at least failed 2 lines of therapy before insurance will pay for this. Hopefully they will. So these are the graphs showing the long-term follow-up of our ZUMA1, which is led to FDA approval for exa-cel, as well as the Juliet trial, which led to FDA approval of teisa-cel, both CD19 autologous CAR T-cell therapy. And you can see here there is a clear plateauing of the long-term follow-up curve, and most relapses were seen within first 3 to 6 months, and beyond that, very few patients end up relapsing. So one key aspect I would like you guys to focus on is a day 90 PET CT scan response. So within 3 months, if your patient is in remissions, there is a close to 75 to 80% probability that that patient will not relapse. So very early on, we can predict that how the patients who have received the autologous CD19 CAR T therapy will do in long term. This is a Transcend study. Again, similar looking outcome, roughly long term around 35 to 45% of the patients will relapse and disease-free. This therapy is extremely well tolerated, at least in the trial setting, and non-relapse mortality was, I would say, almost comparable and even better than what we see with high-dose therapy and autologous stem cell transplant. So with that encouraging results of third line and beyond of CD19 CAR T, 3 trials were launched using all these 3 CD19 CAR T. And the first one I'm going to walk you through is ZUMA7, which we were part of. And these patients were selected based on Scholar 1 of highly refractory or patients who are traditionally supposed to do poorly with the salvage therapy and high-dose, followed by high-dose therapy and autologous transplant. So the ZUMA7 selected DLBCL relapsed refractory patients who had primary refractory disease or had relapsed disease within first 1 year of their initial therapy. Patients were randomized to go receive directly exa-cel versus platinum-based investigator choice salvage therapy, followed by autologous stem cell transplant. Bridging therapy was not allowed in this study. Subsequently, the primary endpoint was event-free survival. And first overall response rate was significantly better with exa-cel. You can see here, these were, again, if you compare it to what was seen in Scholar, the overall response rate here was 83%. Majority were in complete remission versus the standard of care platinum-based salvage therapy, where overall response rate was 50%, which we do see in practice. The study met the primary endpoint with event-free survival, significantly better with exa-cel over standard of care, followed by autologous stem cell transplant. And I would like you guys to focus on the control arm here. If you look at the pink line, the long-term event-free survival was 16%, which was we expected with Scholar 1, okay? And here the long-term survival, not survival, I correct myself, event-free survival was 40% in patients who were able to receive the exa-cel. There was no difference in overall survival, although the data is a little bit immature at this point. We are not expecting that there will be overall survival difference because, as you can see here, roughly half of the patients did end up receiving CAR T-cell therapy on the standard of care arm. So it means that patients who fail the salvage therapy ultimately investigator decided to give them CAR T, and of course they responded. And that's why it is difficult to prove the survival advantage. But however, it proves the point that in high-grade DLBCL who had primary anthracycline refractory disease or disease relapse within 1 year of R-CHOP will benefit more from going straight to CAR T versus getting platinum-based salvage followed by an auto transplant, because most of them will not respond to salvage therapy. However, similarly designed Belinda's phase 3 study was a negative trial, which compared the teisa-cel, another CD19 CAR T versus salvage therapy followed by autologous stem cell transplant. There have been multiple debates in person at ASH and on Twitter about why one study was positive and other was negative, but bearing the difference in the study design and some like the ZUMA7 did not allow bridging therapy, where the other Transform study, which is similar phase 3 study with liso-cel And the Belinda study with T-cell allowed bridging therapy. So people argue, well, these people may be high-grade, much faster-growing lymphoma compared to what was seen in ZUMA7. However, to that, my argument is look at the control arm, event-free survival. Okay, all three studies has similar event-free survival in a control arm. They were all very sick patients with highly aggressive disease. If you look at the crossover CAR T therapy, roughly half of the patients in each study has received CAR T therapy when they did not respond to salvage therapy. So in my mind, I do believe that these studies do change the current standard of care. We are still waiting the update from FDA regarding whether they will approve exa-cel and liso-cel in a second-line setting or not. But these studies certainly are quite intriguing. Moving on to CAR T in first-line setting, Zoomer12 was designed to look at patients with high-grade DLBCL with biologically high-risk disease. So traditionally, double-hit lymphoma, high IPI, who has done poorly with R-CHOP. The study also included a dynamic risk, high risk, which is patients who are supposed to receive at least 2 lines of rituximab with anthracycline chemotherapy and still had a need to have a persistent disease to be eligible for this study. So these are the patients who are not only high risk by biology, but also high risk by response to the treatment. Okay? And these patients underwent leukapheresis and received the exa-cel. It was a phase 2 study, 40 patients were enrolled. And look, this is the overall response rate, quite impressive, 78% complete remission rate. In efficacy evaluable 37 patients, you can see here, majority of the patients were able to achieve the CR. And in the long-term follow-up, the data holds. These progression-free survival curves are unheard of for high-grade B-cell lymphoma with double hit or high IPI. And you can see here, very few relapses. So most of these patients were able to go achieve a CR and maintain that CR. It is likely that not only it's biologically better disease than what we treated in ZUMA1, but we are also collecting healthier T cells because these patients were less exposed to multiple lines of therapy. So maybe they had better quality of CAR Ts compared to what was given in ZUMA1. But however, this will have another long-term follow-up and other frontline CAR T in near future. What else coming on in the non-cellular therapy field? So we have a flood of new approval in the last 3 to 4 years in this disease space after almost 2 decades of dry period. Polatuzumab vedotin was the first drug approved for two-line and beyond in 2019, followed by selinexor. Tafasitamab, which is a monoclonal antibody against CD19, was approved for patients after first line of therapy for relapsed or refractory DLBCL who are not eligible for high-dose therapy and autologous stem cell transplant. And most recently, loncastuximab tesirine was approved, which is another CD19 antibody drug conjugate, has been approved based on a phase 2 study for second line and beyond. So we look at the CR rates. Of course, these are smaller studies, kind of hard to do the cross-trial comparisons. But certainly, these are encouraging developments in the field of high-grade B-cell lymphoma because it gives us many more options for patients who are either not eligible for transplant or CAR T-cell therapy. I have used many of these drugs as a bridge to CAR T or bridge to transplant also. Mosunetuzumab is a very promising CD20 bispecific antibody. Was published in JCO recently, and quite encouraging results, even among the patients who had failed prior CD19 CAR T-cell therapy. And many more bispecifics are currently under investigation, so more to come. So with all of these new developments and new studies, how would I treat high-grade B-cell lymphoma patients with relapsed refractory disease in 2022, if that patient is CAR T eligible and insurance is willing to pay for it? Patients who had second relapse and beyond, of course, the standard of care is CAR T-cell therapy. We have 3 options, exa-cel, T-cell, and liso-cel. However, patients who are primary anthracycline refractory or patients who had relapsed within 1 year of the initial therapy, I would strongly advise these patients to seek care and receive the CAR T therapy based on the ZUMA7 data. However, the transplant is not completely gone. Patients who had first relapse and does not meet other high-risk criteria, which I mentioned earlier, can still benefit from salvage chemotherapy followed by autologous stem cell transplant. Patients who had CAR T failure or not eligible for CAR T has multiple options, non-CAR T options like Pola, Lonca, selinexor. Selinexor, personally, I have not used it, but it's still a reasonable thing to try in a frail old patients who are not able to handle other high-dose therapies. Allogenic transplant has still a role if insurance is willing to pay for it. Again, as you know, Medicare does not cover allotransplant for lymphoma yet, so that limits our options for allotransplant in this age group. But we have done a handful of allotransplant, and we have an abstract coming at TCT looking at a patient who had failed CAR T therapy and undergo allogenic stem cell transplant and had a 40% progression-free survival at 1 year. So in conclusion, future is immunotherapy for high-grade B-cell lymphoma. CAR T-cell therapy has changed the treatment landscape of this disease and relapsed refractory, and it's quickly moving earlier lines of therapy. And in near future, hopefully in next 2 to 3 years, we will be using this therapy and in a first line, maybe in a second line, and a lot more than what we do today. Multiple non-cellular therapy options are quickly moving into the development, and hopefully we'll have more FDA approval in next couple of years, which will help us to get more patients to CAR T and also salvage patients who are not eligible for CAR T. And at the end of the day, every patient needs to receive tailored therapy based on the center expertise, physician preference, and of course, the finances and the patient's overall comorbidities. One thing I would like to emphasize here is that CAR T-cell therapy is relatively easier to do than high-dose therapy and autologous transplant in my experience. My oldest patients we did CAR T therapy is 86-year-old, and she's still alive 2 years after and still in remission. So if you are a community doctor and you have high-grade B-cell lymphoma and you think that the patient will not make it to transplant, please consider referring that patients for CAR T to nearest centers, because there is a good chance that we will be able to collect cell quickly and give the CAR T therapy. Again, the time for manufacturing for XSL is 18 days. Sometimes we get the cells back in 2 weeks. So by the time patient comes for the next line of therapy, and within 21 days or 28 days, you will have CAR T cells ready to go. So this is very quick therapy to do. We are very experienced now with managing the early and late toxicity of CAR T cell therapy. At Vanderbilt, we do all the CAR T therapies outpatient, 100%. We only admit patients if they develop any major complications. So these are, again, very expensive therapy. There are some logistical challenges, but it certainly it transformed the treatment landscape of this disease profoundly for good. With that, I would like to conclude my talk. Thank you so much for listening to me, and we'll address more questions in the panel discussion. So thank you.